to Call In Live with Can TV. I am your hostess, Sister Ya, and I am with Tacts, the Association of Clinical Trial Services, Tacts. And we are here to offer you information on a call in live number on health equity, health issues, and social justice. All right. Now, I know it's normally called something else, but you can call in about anything to do with infectious diseases, STIs, HIV, any of those types of topics. But today we're going to bring the heat to you. We're really going to discuss very specifically what's happening around health insurance. And I want to give you a couple of tips, things to understand about Health Insurance 101. Now, I want you to know that you can call in live at 312-738-1060. And then we have our PC there, Mr. Charles Patton, who is our people's counselor. He is there waiting for you to take your call if you do choose to call in live. Now, what I'd like to discuss with you, again, knowing that we are Tacts, I'd like to discuss with you about excuse me, the Association of Clinical Trial Services. We do believe in diversity within clinical trials, and as you can see, there's several organizations that support this concept, as well as organizations that want to support Tacts. So that's what this is about, and we want to make sure that you get all that information. Now, with this call-in live particular issue, I definitely want to focus on two main things. One is going to be what's been happening for the past month, as in it's March, Women's Month, right? And then the second is going to be, again, I'm going to cover some basic concepts around Health Insurance 101. Again, I am your hostess, Sister Ya Simpson, the community epidemiologist for Tacts. Now, one of the things we want to make sure that we always cover is what is health equity. That's the one thing Tacts is pushing. Health equity doesn't mean are we equally sick. Health equity means do we get the best health possible for ourselves and trying to achieve our life expectations. So equity is different from equality. Equality means you get all the same box. Equity means you get what you need to stand up tall to get to where you need to see and have a better view of yourself. So that is something that Tacts always covers, is because we are promoting health equity, not health disparities, not health. Well, we talk about health inequities, but we are really covering health equities. Let me show you a picture about that. As you can see, there's a triangle to health equities. At the top is policy. We've been hearing a lot about the Obamacare versus Trump care, which is terror care, but nevertheless, policies at the top. At the left, we have what we call the places of industries or institutions, and then in the right we have community capacity building, and in the middle is health equity. That's what it takes in order to build health equity across the board. It takes you to be involved. You are responsible for your health. It is not just the physician, it's not just the providers, it's not just the institutions. The health institution is not the politicians, which we're having a hard time dealing with them and understanding this, but it is part of you, and you are just as part of that triangle as they are, and you are as much as responsible for your best health as they would be. So if you've got any questions about health equity, you don't think you understand it, call me up at 312-738-1060, and we can explain that further to you. Again, it's called health equity. So let's get on to the lesson for today. Today's lesson is specifically around Health Insurance 101. There's a couple of points that I really want you to understand, but let's be clear. The problem is we need a single payer system to lower our control, to lower and control profit costs. Whereas all pay into this system and all should benefit. This is known as universal health care. Now, let's be clear. This country does not have universal health care, and it could. Why do you say that it could? Because a single payer care system already exists. Congress has a single payer care system. Veterans, called the VA, Veterans Administration, has a single payer health care. You don't know, but some people, which we call native or territorial states, have a single payer health care is from the federal government. And then, of course, your Medicaid and Medicare programs are from the federal government as a single payer care system. So, why not expand this care across the entire population? Well, one of the reasons that that's not happening is because when we talk about health insurance, the way that it's set up today is based on established by sectors of population health. What does that mean? That means that they look at certain subpopulations: white males, white females, Black, Latino, Hispanic males and females, youth, ages, and of course adolescents. All of those are topics or subpopulations that they use in order to understand what type of health care or services are needed. Now, obviously, there is a big class system that goes along with those particular subpopulations, and that's what's not talked about as much. But that class system is embedded because you talk about people who cannot afford the care versus people who can afford the care, but they still get subsidies for their care as well. That's what Congress gets. So we need to be specific about these particular sectors. That's one point about health insurances. The other is there is primary through which we call quaternary care services are also determined. So what does that mean? You've obviously heard of primary care, which is about the most general and the most wide type of spread of care that people are familiar with. Then there's secondary care, tertiary, and quaternary. Each one of these types of care services is dependent on what physicians or providers are providing as a service. Primary care is your family physician or practitioner or provider. Your general type of care, of course, that also includes emergency room care. So those are very generalized or family care physicians or providers. Secondary through quaternary care is always about specialization. Secondary care being that if you have cancer, so or diabetes, so there's an endocrinologist or there would be a cancer specialist, right? So these are the people that specialize, or physicians or providers who are secondary. Tertiary kinds of pulls it out a little bit more and goes after other very, like if you had an ENT or a type of specialist that orthopedic specialist. So different specialists have different positions, which in different types of service and care. Quaternary care is really more focused on experimental care. So you still have a physician or a doctor treating you, but like if I was in the VA and I was a part of a study, I had a very specific doctor to see me who was working on different types of cares for heart disease. So heart coronary diseases. He was specialized in that, but because I was in a clinical trial, that was considered quarterly care. So fourth type. Those are the types that are all funded, but they have to get an analysis of how they're funded through the type of physician that work in that care. I hope this is making sense, but I see I have a caller for the We Are Tacts call in live. What can I do for you, caller?
Yes, good evening.
Good evening.
You're right 90%, but not 100%, and I'll tell you why.
Okay.
You want one payer, is that what you said? And then where your country pays for all your insurance, you go, well, why do people come here and get their operation? Because they can get it on time, not be 4, 5, 6 months down the time, just like the VA. I'm a veteran.
I'm a veteran too, and actually, caller, I have to push back a little bit. I'm going to tell you that that is actually not true. Maybe I'll have to say that your experience may have shown that you can get quick, but actually, even veterans now are waiting months for certain types of surgery, depending on how serious the surgery is. In fact, I've had surgery at the VA, and I could have at a particular point have had to wait almost 3 or 4 months, but because I know how to work the system, I was able to get in less than 4 weeks. So that's not true, caller. But thank you for that. I appreciate you putting that out there. Okay, so what the caller was referring to was coming over and how fast do you receive your services for surgery being specific. So let's be clear, surgery is a very specialized type of care. It is not primary care. It is when you have a situation that it requires obviously a surgeon, something specialized and something wrong in the body, and they want to fix it, mitigate it, hopefully, if it's cancer, take it out, or whatever it is that they have to do. That expense is far much more expensive than primary, just general coming in for a what you would consider just a overall checkup. So the expenses there are much higher. However, what you have to realize is no, everybody doesn't get into surgery right away. Not in this country. And people have said that about universal care, that, oh, you won't get surgery in time. Actually, you're not getting it anyway. So we are not doing as well as other countries. That's my point, in that other countries like a Canada or Cuba are doing just as good, if not better than us. Japan definitely is leading us, and they still provide the same types of surgery. But guess what? The reason they don't have the exact high numbers of surgeries and the high numbers of tertiary care or secondary care is because they have a better preventive care system. So callers, we need to think about, and viewers, think about more preventive care, so that way you don't need surgery or you don't need specialized care because you were more preventive care. And that comes with a bigger cost savings with universal health care, which is exactly what Cuba and Canada has already proven. What I know for a fact is, based on epidemiological research, is that when a group of people are more homogenous, or where you live is more equitable, I didn't say equal, I said equitable. When it's more overall about the same, people actually do live longer and they do better when it comes to healthcare, and the price for healthcare is not as high. So I'm sorry to say people's idea of this is not just straightforward. The resistance is not about, is it evidence based? The resistance is about, is profit based. And the people profiting are mostly those from the pharmaceutical companies and the insurance companies. So that's why I wanted to go through that. One more or two more points that I need to make about health insurance is that the care is determined not only by the physician that's treating, but by risk analysis. Fee for services, you've seen that word, FFS. If you ever see that, that's fee for services, and third party services for billing costs. Callers that are looking at this, viewers, those billing costs add up. And they have no other job but to help get your medical services billed. Billing in itself is a fee that is enormously high within the healthcare system. If we only had 101 or maybe a better system of billing, not the type of system of billing that we have now, but a more streamlined billing process, that would also cut down costs. It would also take the profit out of healthcare. So we talk about Obamacare. What about Trump care, which is terrible care, which is terrifying care or horrible care? That type of care would be worse than what we had before Obamacare was even instituted. It is not affordable, and it's not the type of plan that would cover all the subpopulations, and the fact that would make it equitable. Again, not equal, but equitable. And they don't even distinguish those terms. In fact, they would go back to a much draconian system which provide the type of care that was much more of a despair. And the despair would come because of inability to afford the type of care. So if the caller thinks surgery is bad now, if that so-called Trump care passes, then affordability will not, it will be the worst aspect of it, but people will just not get surgery, and still their life expectancies will decrease, and their life quality of life will decrease as well. So I hope people got this. This was just the tip of the iceberg. I'm going to continually push for universal health care. As an epidemiologist, a community epidemiologist, we are dedicated to this because the evidence has shown that around the world, people who have bought into the concept, countries, even South Africa is doing better, who have bought into the concept of universal or single payer care systems have done better. Because what's the point? The point is to have a higher quality of life, longer quality of life, better health. And if your health is not healing and is hurting, we need to fire some folks. I don't believe that insurance companies should be given money and should profit off the fact that you still haven't been healed. I am one for who feels in other countries that do this. If you do not heal the person, correct the issue, make their health better by benchmarking where they were before the surgery or where they were before your care, you give them the care, and where they are after. If the after isn't better than the before, you don't get paid. Now that's hardcore, but that's how I feel about it. But evidence does show that universal health care can be done. And again, viewers, is being done for selected populations anyway, whether you accept that or not. Medicaid and Medicare is a single payer system. People in territorial, we call them state territorial reservations, single payer system. And the caller just talked about me and there's several others coming up, veterans, single payer system. Why we're not including the rest? And in fact, it would bring the healthcare costs down if we did that. So I hope you got that aspect of it. I really wanted to just do an insurance one-on-one. And again, we need to make sure that we are involved with understanding if we all pay into the system, we would all benefit from the insurance system. Everybody has to give in something, but some people have to give up more. And that would be the people that can afford it. That 1% or the Congress, my congressional people, those congressional individuals can't afford a type of health care that someone who's on Medicaid cannot. Why should their life be any better or the quality of their life be any better just because they have the money? The money isn't what makes their health. It is the advancements and the social science that has been socialized to give us better treatment, advanced treatment, better care, quality of life. That is what has helped them to have better health, not because they earned it through their money. Not in a capitalistic system, and darn sure not in an exploitative system, which we have between insurance companies and pharmaceutical companies who have profited off of people's demise. Now, I say that because that is what truth is, and I'm going to speak truth to power. I have friends that work for pharmaceutical companies, and they have to earn a living. So we don't have to say the people that work for them are evil, but we can say that the profiteering is exploitative, and it needs to be wound down. We can find other ways for them to profit. It just shouldn't be off the backs of our ailments. They can profit in other arenas, but it shouldn't be because of treatment, and it shouldn't be because of healing. And that's what makes this system so hard to fix in the United States. So that's one of the things I wanted to dwell on is Health 101. Also, guess what else happened this month? As it is Women's Health Month, we had National Women and Girls HIV/AIDS Awareness Day. That took place. It took place March 10th. And I was a part of the TPAN Test Positive Aware Network, TPAN's event with women and girls, and it was a great event. I just thought about it. I should have put some pictures up from it. We had such a good time. Myself, a representative from Gilead, Ernie was there, Ernest, and then another lady was there. She was a sex therapist. Ooh, I liked her though, honey. She was talking about how we should be having good relationships, which comes with healthy sex lives. All three of us really wanted to go on the fact that just because women are impacted by HIV or affected by someone in their family who's HIV positive doesn't mean that their whole lives are over, or for that matter that they have to have a lower quality of life. That was the message that the women were getting. And if any of them were watching now, I tell them, I stay woke. So that was one of the things that I was telling them. What if there was but only master teaches I stay woke. And I'm saying that to mean we have to be involved in the game. Just because when we talk about the number of new cases of black women, specifically in Chicago, of the number of new cases there were about, and this is on the fact sheet if you were interested in. I know you can't quite see all the writing on there, but if there were 143 cases of women who were newly impacted or newly infected with HIV in 2015, of that 143, 122, which is 85%, were black women. But black women among all groups are the only group that is less virally suppressed, which means they're only virally suppressed at 44%. Now, viral suppression means that they don't have as much virus in the body, and it keeps the body from passing on the virus. Viral suppression, we are trying to get people to, of all the people that are living with HIV, we want viral suppression at 80% for all the people that are positive. But we cannot get to that 80% if black women are only at 44% for viral suppression. So, sisters, what are we going to do? We're going to stay woke. And that's one of the reasons what I was bringing to the table for Women and Girls HIV/AIDS Awareness Day is be aware that now there are advancements of treatment with the advent of all these treatments that help to keep the virus down in the body or lower the virus level in the body so you don't have as much, as they would say, viremia in the body, or the concept is then you're less likely to pass it. And if you're virally suppressed, then of course the concept is your immune system is open, is better, is engaging, it's working. We want to improve our immune systems. We want to be less likely to pass on the virus. So how do we get to that, sisters? We get to it by getting to be virally suppressed. And that means a CD4 count that is under 200, or a viral load copies per milliliter that is under, now we're saying, using the terms, we're going to say under 50 copies per milliliter, depending on your lab, but under 50 copies, we know that that is virally suppressed. So we really want to push those ideologies. If you are not HIV positive, you can use what we call PrEP, pre-exposed prophylaxis. It will prevent, more than likely as high as 90%, from you contracting HIV from a person who has it. And so we want to make sure that we put that in our armamentarium of prevention tools. What that means is you could take PrEP and still use a condom, and if someone is positive, you don't get it. But the real deal is, if they're positive, did you get tested? So we want to make sure that all of our ladies know that you have to get tested. And there are plenty of organizations out here, from Men and Women's Prison Ministry to the Brothers Health Collective, who does testing for HIV and hepatitis, the AIDS Healthcare Foundation, who does the treatment. CFAR does all types of research around this, and we have our Southside Health Collective. So there are all kinds of entities that are there to test you with, but more importantly, you need to get tested. I want to remind people that as we move forward, there are several events coming up. I, again, was very, very elated to tell you about our new campaign, which is Health Equity Equals What? Black Unity, Moja, the healthcare campaign. This campaign is geared toward blacks trying to get better service from their healthcare. We're going to focus on from population health to health care systems to types of health that I just described, specifically cancer, HIV, of course, STIs, violence prevention. But we have to know that we are accountable, liable. There are repercussions. We have to have the right perspective. So these are the type of campaigns that I'm going to be working on. And I would like to make sure to remind you that as we work on these campaigns, you should be looking out for us. Save the date, Friday, May 12th. May 12th, Friday, 2017, at Mercy Hospital, the Women's Health Week Networking Social. I am so excited about that social, because that is where we will be paying homage and honor to the women who have been righteous contributors for healthcare. So as I wrap up today, don't forget, stay woke. The sun didn't rise, you did. And more importantly, become a master teacher. My name is Sister Ya. I'm your community epidemiologist, and I want to thank my partner here, Mr. Charles Patton, who is PC, the People's Counselors. Call us up if you need any other information, 312-961-6189. Hit me up on Facebook, Tacts us, and I hope to see you soon. Sister Ya.